discussing personal reflection and journey around the globe of UBE adoption. And we have wonderful speakers presenting tonight. Before we get started, we will have Chairman of the SMISS AP Annual Congress in Mumbai 2025, Ayush Sharma, giving us a little glimpse of what is prepared in Mumbai with a little video and introduction.
So thank you, Choi, and greetings from Mumbai. We are all waiting to welcome you at Mumbai. Let me share with you our the website. I hope you can see it. Can you see, guys? Yeah. Can you guys see the website open there on the screen?
Yes, we can.
Yeah. So basically, if you go through it, it has all the information that you need to know. We have the program which learns into 4 days. It starts with day 1 with some beautiful live recorded videos. It covers everything in the spine surgery, especially when it comes to minimally invasive spine surgery. Going from there to day 2, it goes into different section. Will cover everything which you want to know, from monoportal to biportal to anterior approaches. We have a big lineup of faculty. We have more than 40 international faculty. All the big names in MIS are going to be there. And we have a lot of good, bright Indian faculty as well. So, we are looking forward to welcoming all of you. We have a feast lined up. And, just to give you a glimpse of how it will look like, let me show you and play a small video, which sort of, represents what to expect. So this is just a video to show you. So the venue is Taj Mahal Palace Hotel, which is a 175 years old hotel, one of the most iconic hotels in India. And we have a 4 days of knowledge sharing with all the minimally invasive techniques you can know of. So visit the website if you want to know. It's called SMISS Mumbai 2025.in. And if you have any question, you can reach out to me. I'm Ayush Sharma. I am a spine surgeon based in Mumbai, or Choi, or anyone from the team. We hope you all will join us, and let's come together and enjoy the minimally invasive spine surgery discussion. Over to you, Choi, and hope and wish you all the guys very best for this webinar.
Thank you, Ayush. Wonderful Congress ahead in July, and we would love to see you all there. So tonight's topic will be kicked off with Dr. Liam Rose. He's a spine surgeon, orthopedic spine surgeon from London, St. George's Hospital. He's currently doing his fellowship here in Melbourne, and he's going to talk about his personal journey, motivation, and some of the learnings and challenges in adoption of unilateral biportal endoscopic spine surgery.
Hi, so thanks for the introduction, Dr. Choi. So for those who don't know me, I'm a UK trainee, and I'm just going to share my slide here for you so you can see. So I'm originally from, as Dr. Choi said, from St. George's Hospital in the UK. I finished my ortho. I hope you can all see this there. And basically, my background is that I always did back at home through my training was always doing open decompressions, open discectomies, as many people will know. I didn't even do tubular. Tubular wasn't something that I really had much exposure to. I didn't use a microscope. All of my former bosses used to use loops, and so it was very old-fashioned the way that we did it. We would split off that multifidus and go down with the loops, constantly sucking, lots of bleeding, lots of swearing. Unfortunately, in the early days when I found it really frustrating to pick up, but eventually got myself through the open learning curve. And the patients, as you'll all be aware if you perform open yourselves, they stay for a couple of days afterwards. They always a little bit sore. And I just kind of thought that there might be a better way to do this. And in the UK, there was it's quite new for people to pick up endoscopic spine surgery, but most people were trying out uniportal. Everyone around me was kind of dabbling with it, going on courses, going to cadaveric labs, and mainly in the public sector were kind of dipping their toes in the water of uniportal endoscopy before kind of breaking out into the private sector. And there were some reasons that people wanted to do that. It was seen as perhaps a little bit trendy. People wanted it in the private sector. There was a fairly obese patient population in the UK, and it was seen as potentially an easy way of getting around that. But by and large, no one in the UK that I really spoke to truly believed in endoscopic spine surgery. It was still very much seen as a little bit of a fad, a little bit of a marketing tool. No one really bought into it, and as such, no one really bought into the idea of properly learning it. And so I decided that I wanted to actually really explore this option. So my first fellowship was coming out here to spend some time at the Spine Ortho Clinic with Dr. John Choi to actually learn proper endoscopy and to see it properly and how it should be done. And I won't lie to you, I had some misconceptions starting about it. I honestly, when I first before I ever met Dr. Choi, I thought he might be doing uniportal, to be quite honest. And it wasn't until I started up with some conversations, started following, some social media posts that I realized, oh, actually, he's doing something biportal here, which is something that in the UK was kind of not really heard of it, because even uniportal was such a rarity that biportal was a really, really out there concept for us. But we actually had some visiting some visiting surgeons from China that came over to watch us do our scoliosis work. And they would tell us about their endoscopic journey. And it was when I was speaking to them that they were telling me that, a lot of them, they started uniportal in their early days, and they've now switched to biportal because of the advantages of that, which we'll kind of come to. And they really sold the idea to me. And I did consider going to Korea to learn it, but there was going to be a huge language barrier with that. And as serendipity would have it, I came across Dr. Choi's fellowship and got some good recommendations from it. And thought, you know what, this is a really great opportunity to go to a cool country, an English-speaking country foremost, where I can go and get actually trained in this properly and really see how it's supposed to look. I just want to show you a little glimpse of my first proper endoscopic experience, and I just want you to really pay attention to this video and what you can see around you, and just kind of get an idea of how this would differ from your typical open surgery. Excellent. Well, I'm just going to skip on from that just so it doesn't keep replaying. So, what did you notice there? So, what I noticed straight away the first time I stepped into the OR and started seeing this happening is I noticed that it was prone surgery, as you would expect. And there was some ingenious use of cesarean section drapes because, you know, a lot of orthopedic surgeons will have their memories of arthroscopy as being, you know, take your socks off because you're going to get wet shoes. I saw two small ports. I saw a very standard 4mm arthroscope with a 0° angle to it. I saw a very simple but ingenious UBE instrument tray with rotating kerrisons and some interesting dilators. I saw that there was a standard arthroscopic RF wand. I saw that there was a simple burr, slightly different attachment to what I would have normally used, but there was basically nothing in theatre that I kind of already hadn't seen. There was nothing really new to an orthopedic surgeon, at least anyway, that wasn't already going to be readily available to me. And my initial take home was that actually this setup is surprisingly more comfortable and simple than I expected it to be. I expected, you know, to be coming across lots of new pieces of equipment and instruments, just as I had this preconception with the Uniportal that was going to make it a little bit more of a journey than it was. But the nice thing is that I could kind of actually concentrate on the surgery and the execution rather than have to worry about kind of getting used to new equipment. So what I saw and what I liked, so I saw that it was a very easy setup. It was not particularly difficult. The theatre staff certainly didn't struggle with it. You had huge TV screens around the operating theatre. So there was a slave screen as well. So your assistant on the other side could look without turning their neck. It was great for observers and people learning because unlike if you think back to when you were bumping your heads with your boss, both fighting for that little one-eye glimpse down the open McCulloch retractors, you could see absolutely everything in clear daylight. And it was really clean surgery as well. It was very clean. The blood was kind of, the bleeding was maintained because you've got some pressure of water in there. You were constantly washing things away. I did think to myself, medico-legally, coming from the UK, a very litigious background, this is fantastic. You can take photos and videos and you can prove to people what you've done, what you've seen. And, you know, there's no kind of, you know, he said, she said. It was all there in full multicolor that you could see everything you were doing. And very selfishly, I found it very comfortable as well. I wasn't reaching my neck over to look down a deep, dark hole. I wasn't squinting my eyes to you know, fight with what I could see. I wasn't, you know, struggling with making sure that my loops were exactly pointing in the right direction and my focal length was spot on for everything. And it was very easy for me to look straight ahead, and my hands were at kind of belly button level, which was a very kind of ergonomic position to be in. So pretty quickly, I kind of fell in love with UBE because I thought this really is, even if it's absolutely on par in terms of results with open surgery, one thing I can certainly say is that I don't think I'm going to fall victim to, you know, you get what you treat, and I end up with terrible neck pain in the future because I've spent my entire career looking down, reaching my neck, being in really, really bad posture, which we always tell our patients not to do. But that wasn't the case. The patients recovered very quickly, much quicker than with my open surgeries. And we thought we did pretty good open surgery, but, you know, it just goes to show that, you know, there's always room for improvement. And the advantages that I saw over open decompression, which is my journey, is that there was significantly less muscle trauma in terms of, you know, you do have to, you know, dissect a little bit with the radio frequency. But certainly I thought to myself, this is why they're not in so much pain. There's a smaller wound. And, you know, maybe there's something in that about long-term multifidus function in the future. You know, you're not completely devascularizing it. And one thing that I thought was quite interesting as well, and again, I'm not really aware that there's much evidence out there, but I thought this is really washing away a lot of the inflammatory cytokines, much as, you know, if you kind of believe in the concept of, you know, high volume epidurals and things like that, you're really constantly washing everything away. And I thought that, you know, there's a really good option in terms of limiting your kind of inoculation of any infection, because you're constantly irrigating this wound out, much as if you were doing an arthroscope of a shoulder. That is your treatment for infection. So you can see how, you know, this was starting to really appeal to me. The magnification of view was fantastic. You had this big, beautiful 4K screen that you were looking at, so you could see absolutely everything in multicolor, and you could see all of the small things that you just couldn't see underwater with a little bit of bleeding down the McCullochs. We've kind of talked about the head position, the arm position already. That's a massive advantage, and I think that shouldn't be overlooked by anyone who's considering their journey as switching to UBE in particular. Because one thing I found when I did some cadaveric courses doing uniportal is I found my shoulders were a lot higher, and it was a little bit uncomfortable, but certainly I didn't find that with UBE. And because you've got this amazing magnification, you can be so much more precise with your very much bone preserving cuts. You don't have to take a huge amount of facet. In fact, it's actually quite difficult to take a lot of facet, I think, because everything's so magnified. You think you've taken way more than you have. And when you start looking at your post-op MRIs, you'll realize that actually, gosh, you can hardly tell I've been there in terms of the facet. You can only see a tiny little laminotomy window if you look very carefully. So I think that's great in terms of, you know, limiting any potential iatrogenic instability. And I didn't really see that there are any additional complications which had to be considered. I wouldn't change my consent form for anything in particular for UBE. I wouldn't add anything on, certainly. And there's good evidence here, and I've just made a little link there that talking about some of the actual proven benefits of UBE over open microdisc. And it does show that the pain is less, the length of stay is less, the bleeding's less. And this is not a marketing tool for me. This is actual genuine real life, you know, patient journeys, and it was great to see these patients leaving the following day, and I'll kind of touch on that a little bit more later. There were some disadvantages of making the switch, and I would be remiss if I weren't to tell you that there are some obvious and some less obvious disadvantages to kind of going through that journey. And I can see why some people might be reluctant to do it, because there is a bit of a learning curve, and you've got to really do this thing solo for a little while to get very good at it. You know, I'm in the very comfortable safety net area where I'll do a little bit of a UBE, and Dr. Choi will be there to kind of guide me through, bail me out of any problems. Not that there's been particularly many, but you know, there's definitely a nervous element to that. But eventually, this definitely is a faster technique. So, you know, I think you've got to bear with that. There's not many opportunities to learn this skill, and I think that's a mixture of not many people doing it, so there's not many people to learn it from. Those that are doing it don't necessarily speak your language, and most places that I know speak either German or Korean, Chinese, and that just wasn't an option for me to go and live in a country and that wasn't English speaking. I would have found that too difficult personally. Cadaveric courses are not that frequent, and they're often quite expensive as well, and they tend not to be so industry funded. And I think that's because the gain for industry to make money off biportal is a lot less than uniportal, and I think that's why we get pushed uniportal a lot more. So that's definitely something I've come across, and now that I know more, I know how to argue against that. And that would be obviously a completely different conversation. If you wanted to talk to me about that, then you're welcome to get in touch. It really suits orthopedic surgeons a lot better. So I imagine if you're a neurosurgeon, perhaps I'm just guessing here, but you perhaps might not find the learning curve quite as easy as an orthopedic surgeon does, because they're very used to the equipment and the triangulation. So that's something to bear in mind as well. The wounds do leak afterwards because all of the water comes out, and it takes a little while to get I imagine personally introducing that to the UK, the nurses are going to freak out on the ward for the first couple of months before they get used to that. And even though it is cheaper, there is going to be an additional cost to this, because you're going to be a little bit slower at the beginning. You're probably going to have people trying to persuade you that it'll be quicker to do open. They might not necessarily want to buy you, some of the very minimal equipment that's needed, or they might see that the consumables are not worth it for them. I personally see these problems coming my way, but I think there's enough here to really tackle this. So Setting up UBE in a new centre would be really challenging, I think, because I think you potentially would be on your own. But mostly hospitals will have everything that you need in their sports arthroscopy kit. You will need to buy some UBE trays. I priced them up in the UK. They were pretty expensive. You probably need 2 to 3 of them. Getting your nursing team on board. Your colleagues might criticize you at first, particularly if they're perhaps a little bit old school, and they might go, but there's nothing wrong with this and there's no evidence. But, I've just shown you some evidence there. Getting management on board, it might be a bit tricky as well if it's going to slow you down for a few months. And one thing I would say is the NHS is actually the perfect place to set this up, because they love day case. And I heard a few of my colleagues talking about how a lot of private hospitals don't like day case because of the remuneration. But actually, if your hospital is into day case and it's financially viable, then this is a really great option. And that would be your key selling point. So my journey started off doing left-sided first because it was easy. I was right-handed, and then you then go over the top decompression, do the bilateral, the contralateral side, and then started having a go at right-sided discectomies, and then eventually we then graduated to doing extra foraminal work, and I've not done yet, but I've seen some UBE T-lifts, and it doesn't look like it's a terrific jump. I think you would get comfortable reasonably quickly doing that. And then obviously you can do it in the cervical and thoracic region as yet, but I think that's, kind of A-level skills. And I think you probably ought to be doing it for a year or two before you jump into that. But it's possible, and the results are fantastic. So what would be my advice if you wanted to get started from an open point of view? So you're going to be au fait with the open decompression already. Decide if you want to do uniportal or biportal. The choice is yours. Go observe, do some courses. A fellowship or a visitation would be great, even if you're an established consultant. And the biggest thing I think for me is to just get going. And I think that's going to be a bit of a gulp moment. But that was my journey. That was my experience with it. That's my kind of 2 cents on my indoctrination to UBE. I love it. I think it's fantastic. I definitely think it's the future. I will never look back to open surgery again unless I absolutely have to for a different reason, such as scoliosis. But definitely get in touch with me if you want to discuss my experience on the fellowship, or if you want some advice on fellowships and visitations. I've got some good help for you. If you want to talk about the general setup or technique, or you want a little bit of information on how I'm going about this, or if you wanted to talk about courses that we would recommend, which I've heard of or have been on, and just generally send me an email or follow me on LinkedIn, and I'd be happy to answer any questions you have. And if you have any questions now about my journey from open to biportal, I'll open them to the floor, and I'll hand you back to Dr. Choi.
Thank you, Liam, for that informative lecture on your personal journey and experience taking on UBE. With the format the way it is through YouTube and OrthoTV, we'll have to collect questions through Gaurav, the administrator. So we might collect the questions at the end and address it. And I'll introduce the speaker, Dr. Ophelia Wan. She is a surgeon based out of Hong Kong, and she has recently completed her AO fellowship in several countries, including Singapore, Australia, and Canada. And she will talk about her endoscopic journey and some of her perspectives on adoption of endoscopic journey as a spinal surgeon.
Hello, everyone. Is the screen share okay? Hello, this is Ophelia from Hong Kong. Thank you, Dr. John Choi, for the kind invitation for me to share my personal journey to UBE. So a brief introduction about myself. I took the FRC Ortho Fellowship exam in 2020, and then I started my spine training in 2021. I started by learning conventional open posterior technique, then MIS tubular decompression, and now I'm beginning my journey into endoscopic surgery. So today I'm going to talk about the barriers to adoption of UBE in my practice. So I'm just a beginner and I'm still learning. I hope today to be able to share with you a story and tell you the 10 lessons I have learned beginning my UBE journey. This is where I work. It's the Princess Margaret Hospital. It's one of the 7 trauma centers in Hong Kong. So talking about the situation of UBE in Hong Kong. So this is the situation. It is mainly performed by orthopedic surgeons within the public sector. And one center started in 2017, while most other hospitals only started 1 to 2 years ago. And now there are around 8 hospitals that would regularly perform the procedure. So embracing a new technique can be very daunting, especially when people are very comfortable with what they are now doing. But if you never start, you will never know. Before talking about the barriers to adoption of UBE, what is actually required to learn a new surgical technique? First, you have to be a motivated person to learn. And second, you need a mentor to guide you. Then it is down to the resources of your center, whether you have the case volume, the match complexity, the equipment, and also the theater section. So this was how I started. I first came across the technique during a conference, and then I started to learn more by watching videos and readings. As the technique was relatively new in Hong Kong, so I traveled to attend cadaveric sections, hoping to gain some hands-ons and some practicing. Lesson 2, be an adult learner. You may not always have a teacher to teach you. But having said that, there are still a lot of great mentors who are very willing to teach, and we all learn by imitation. And this is invaluable for you to have a mentor to guide you during your surgical training. I have the honor to have learned from Dr. Elsa Wan in Seoul, Dr. Dennis Hay in Singapore, and Dr. John Choi in Melbourne. So lesson 3, reach out to a mentor. Here comes the real barriers after you have started. So I'm going to talk about them from preoperative, intraoperative, and postoperatively. So the ideal beginner case might not always be there. So people would suggest you to start with a discectomy, a left-sided herniation with a unilateral nerve root impingement, preferably in the L5S1 window, because there's a very large interlaminar window. But when we work in a busy regional hospital, our first-line management would be 6 weeks of physiotherapy. And thankfully, most of these patients would improve and they will not need surgery. So these are our day-to-day cases. We have elderly population, they have multi-level degeneration, 3 to 4 level at the same time. And they also have instability and back pain, so which might not be a good candidate for UBE. Again, like every public system, we have resources limitation and a waiting time. So our team has a waiting list of around 180 patients. So even if I find a suitable patient today, it will take some time for me to schedule the surgery. Start UBE, you will need to acquire an endoscope, a radio frequency machine, and a burr unit. Unfortunately, gathering these instruments was not too difficult in Hong Kong, as there are already some suppliers when we started. So water management is important. We were able to get this endoscopy drape. It's from Korea, but unfortunately, because it didn't have the certification required to be used in our hospital, we have to work around it. We have to create our own drape with multiple water pouches. Let's move on to intraoperatively. We were super new to this procedure. Fortunately, I have a very supportive friend and a very experienced surgeon who was willing to watch my back. So this was him right next to me while I started my first case. And a big thank you to Dr. C.Y. Low. He has been a great surgeon, an awesome teacher, and a very supportive friend. So lesson 4, find a buddy. It takes a team to start a new technique, and we also need to communicate with the anesthetist about the procedure. Without a proper BP control, hemostasis can be very challenging, and it would affect the visualization and the efficiency of the surgery. So teamwork is very important. So this was our first case. Our first case was a 2-level over-the-top decompression, which took us 4 hours per level, which was not desirable for the patient and for the whole team. So time and efficiency was a huge setback. And we are all here to serve our patients. Post-operative outcome is very important to the success of a new technique. So I would like to walk you through my first case, which was a very, very painful experience. This was a 65-year-old gentleman with symptoms of spinal claudication, 2-level stenosis over a bilateral L5 and S1 region. So we performed the 2-level UBE. This was the patient who took us 8 hours to complete. After the surgery, he felt his leg and sole numbness improved. But then there was a new onset withdrawal. The right ankle and right big toe was weak. We were worried. We did a follow-up MRI. So you can see the pre and post images. So there was no hematoma, no collection, and the 2 levels are very adequately decompressed, and we can observe the expansion of the dural set. Very fortunately, he improved after a course of physiotherapy, and the power gradually returned after 1 week. So our postulation was due to prolonged surgery with pressure effect from the irrigation fluid. So we were very eager to learn this new technique when we started, but we overestimated our ability. So please learn from my mistake. Find the exact right case to start. Do not attempt a 2-level decompression as your first case. Finally, it's this very steep learning curve that could set you back. But it is important to recognize this is not just for you. The learning curve is for everyone. So according to a meta-analysis, it would take 37 cases for a surgeon to reach proficiency. And proficiency was defined as 75 minutes from another study. And a trainee with no experience would reach adequate performance at 58 cases. So let's just keep practicing. This was my journey so far. So I started my first case with some confidence. I climbed up, I was at the peak of Mount Stupid. And then it took me way too long to complete the procedure. Patient was not doing fine after the surgery at first. I fell onto the valley of despair. So hopefully now I'm slowly climbing up this slope of enlightenment. So this is 6 months down the road. We are able to take out bigger and bigger chunk of the flavum, and hopefully we can catch butterflies one day. And this was the patient I told you. He's now very happy. He's now symptom-free. And after all, it's been a very rewarding journey. Lesson 8, be perseverant. So to overcome all the barriers, I come to learn what is in our circle of control and what is outside my circle of control. And I will focus on the things that I can control, plan ahead, find the right patient, keep learning, keep practicing. So this is the lesson 9. Maximize your circle of control, and hopefully one day I can expand, I can increase this circle of control. And I hope everyone would be able to find your flow. It's a sweet spot when your skills perfectly match with the challenge of a task. This is a state of optimal performance and sense of enjoyment. Be the best you can be. This is the last lesson. This was taught by my respectable mentor, Dr. Choi, who told me he cannot unsee what he has seen. He's a pioneer in minimally invasive surgery, and he's still pushing for innovation and excellence. And I'm so honored to be one of his mentees. So thank you, Dr. Choi, and thank you for your time.
Thank you, Ophelia, for that incredibly enlightening talk with a lot of philosophical insights into learning a new technique that we all can learn. I have had some questions come through, one of which is, I'm an expert tubular surgeon, and this endoscopic mumbo-jumbo is not going to be any better for me in terms of speed or efficiency. is what would you say to counter-argue that statement, both Liam and Ophelia? Maybe Ophelia first and then Liam second.
So look at the patient. So patients are able to walk with very minimal back pain just after the surgery. And this is very satisfying. So once you've seen it, you cannot unsee it.
I would say to that there are two people in the doctor-patient relationship, and yes, you might have a really good outcome with tubular surgery. There are advantages; it's been proven. There's good evidence to show the advantages, and if for nobody else, if you still cannot convince yourself that the patient is going to benefit from you going through that learning curve, then do it as a service to yourself, because it's a very good ergonomic surgery. It's very comfortable to do, and it's very good for everybody else in theatre to be able to see what you're doing and learn from you. Don't just be selfish with your skill because you're the only person that can see down that tube. Spread the learning, and also look after yourself, look after your own neck, look after your rotator cuff, because you never know, you might be that patient one day who's on the sharp end of the endoscopy because you've had years of craning your neck to look down a tube. And I certainly would say it comes to the point of, don't knock it till you've tried it. Just go and see it and then make your decision. Don't dismiss it before you've already had a chance to look at it properly.
Yeah, don't judge the book by its cover. And also, I think one additional comment to that is that tubular surgeons doing multi-level stenosis cases struggle enormously. And I think the benefit of endoscopic surgery potentiates and multiplies when you start doing multi-level surgery. And I'm sure 3-level, 4-level stenosis cases or tandem jumping stenosis cases of the lumbar spine doing tubular technique can be very taxing and difficult. And contralateral far out decompressions, in addition to central decompression, is not as easily executed or as sophisticated as endoscopic surgery means can be. With that, we'll move on to now a different perspective. I guess an expert surgeon or a master surgeon or master of nothing, Dr. Stephen Yang, surgeon from Brisbane, who's going to talk about why he, at his peak of his career, decided to switch from what he was good at, doing conventional surgery, and took on this arduous journey of endoscopic surgery, in particular biportal surgery, and his experience. Thank you.
Hi, everyone. I'm from Brisbane, Australia. I've been in practice for 20 years, and I was really known for my work in deformity surgery and revision surgery in Queensland. So I was just trying to get this to share this screen with you. As you can tell, I'm a dinosaur and really not very good with technology. Where's the share screen? Share. Can everyone see this?
I can't see it.
No? Green. What about now?
Yep,
Just give
we
it
can
a
see it.
minute.
Start the show, please. Yep.
Okay, so basically, I started this very late in life, and the reason why I started this, if you can see the MRI here, this is a 52-year-old orthopedic surgeon who was deadlifting 120 kilograms repeatedly and had sudden pain in the back. And then he went down the leg with a partial foot drop. As you can see, the 4-5 disc had gone in a cephalad manner, taking out the L4 nerve root. Okay, and he's got a slight spondylolisthesis at 4-5 and some compensatory retrosthesis at 3-4 in dynamic views. And he was a bit concerned about the ankle dorsiflexion weakness. So, and this is me 2 years ago. So you can see why I had a vested interest in it, because at that stage I was doing some uniportal endoscopy, and I found that was quite difficult for logistical reasons because of the cost. Every time I want to use it, because the hospital didn't have the special setup, we have to get the company to send it, send the rep, and had to use the image intensifier in there and wear an X-ray gown. Prior to that, I was doing all my decompression work, discectomy, ACDF, all using a microscope. So I didn't have a neck issue using the microscope, and my whole team could see what I was doing, right? So it was not really an issue. So it started because I wasn't attending any spine meetings. I was doing my own thing, running races around the world, and being a middle-aged surgeon, was comfortable doing what I was doing till this happened to me. So I started going to meetings again because I couldn't go overseas and run and train these young people. So happened that 3 weeks into my sciatica, I was at the Globus robotic lab. I don't even know what I was doing there, and happened to be sitting next to John Choi on a bus to the airport. And he said to me, "Hey, Steve, you should be doing this stuff. I'm going to Korea in 3 weeks. Come with me." So I found myself in the plane literally a few weeks later. So why should older surgeons who are well established, very comfortable with what they're doing, we're getting good results, why should they really change what they do? I think, there are a lot of barriers because it is stressful changing your whole theater setup, changing, your comfort zone, and increasing operating time. And you have to reduce the number of cases you do, because by this stage in mid-career, you're very busy. And also, when you start something new, you look a bit incompetent, right? And you've got your junior surgeons, your fellows, your registrar looking, you going, "What's this guy doing?" So, it is very difficult to go back to being a learner again, particularly when you have no mentor, you're doing it on your own, you're trying it out. But my argument is the older surgeons should be the one trying out new techniques, because unlike young surgeons who are on 4 different learning curves, doing deformity, MIS, doing ALIF, doing whatever, they're on multiple learning curves. You are on one learning curve, right? So you are in a much better place to be learning any new technique. And above all, you have the operating team and the hospital administrator understanding that you're learning something new. You're not digging around being incompetent, right? And also, if you have trainees and fellows, it is very attractive because they are not really interested in your retirement. They are here to learn new techniques to enhance their future careers. So I started nearly 2 years ago now, and I was doing some uniportal, but it was very resource intensive and quite expensive. And it's very difficult at that stage because hospitals were, not making money at that stage. So I was sitting next to John on the way to the airport, and I went and saw this thing in his theater and then in Korea. And what I did was I knew the particular problem of people going to labs and workshops and kicking tires but not really getting started. Once you don't get started, after a few months, you'll never get started. So before I went away to the cadaver course, I actually booked up 6 cases to come back to. So I had no choice but to get started. So, yeah. And unfortunately, I am one of those guys that once I get started, I just feel that there's no easy way, and I don't wait for easy cases. I just stack them up. Whatever comes my way, I just get them done. And the most difficult thing to do, I think, is that because you are comfortable with other techniques, you want to fall back to your comfort zone. It's like if you are a good skier, you take up snowboarding, you want to go back to skiing. It's the same thing. So for me, the biggest thing is that when there is a sticking point, when it gets really tough, I resisted all temptation to convert. So I've never converted a single case after 150, because if you convert, then it's easy to convert the next time and you never get past the sticking point. So, and these are very early results. I saw this 76-year-old guy with stenosis, and this is a 12-hour post-op. And when you do open surgery, laminectomy, their neuropathic pain goes, but I tell you, they're not bending like that and running around off their medication. So for me, a microdiscectomy, my patients can go home the same day. I don't really see a big advantage there, but I think discectomy is really important because it gets you the numbers to get good at doing decompression. Because I think a bilateral decompression is where the sweet spot is, be it 1 level, 2 level, 3 levels. I think because of limited muscle dissection, they get going quicker and you don't actually do anything to the disc. When you do a discectomy, I think they do get back pain because of the disc disruption, whether you do it endoscopically or open, right? So this guy, he was ready to go home same day, but he couldn't go home because the wife has motor neuron disease, so couldn't pick him up. So for me, decompression is where the real advantage is. And also I have very, very obese patients, okay? So this is a patient that is not that uncommon. You can see the spinal needle, which are 10 centimeters, and one's hub down there and it's not touching bone. The other one's just touching bone. So, with open surgery, it's very difficult. My retractor's not long enough, and sometimes my instruments are not long enough. So with endoscopic surgery, I find doing this sort of patients not as challenging. There are still some challenges when my instruments are not long enough. So, BMI 30 is considered normal size now. 35 is a new norm. This is actually a normal size patient for me. There are larger ones than this. As you can see here, the scope sheath to retract the nerve root is hubbed down to the skin. I have to push against the fat to get the retractor down to the disc. And this is not a micro pituitary, this is a normal pituitary running out of length. And the week before was a guy, and the scope sheath was not even long enough to get down to the epidural space. So there are challenges, but it is much better doing this way than open surgery with really fat patients. And then the other advantage for me, my cervical surgery done from the front, they are pain-free, they can go home the same day if you want to, they're back at work 2 or 3 days, they work in office, and there's really no muscle dissection at all, anterior surgery. So for me, the advantage of doing endoscopic surgery in normal patients that I see is not a huge leap. But for patients like this, for example, with the C5 hemivertebrae, really no movement between 5-6 and C6, C7, and then she goes and have a C7T1 stenosis, what do? If you do the usual ACDF at C7T1, then basically you've taken out all movement between C5 to T1. So in this situation, because the main problem is reticulopathy from the C8 nerve root, I've done biportal, that's cephalate, that's caudal, that's medial, that's lateral. I did a partial facet resection, free up the nerve root without having to do a fusion. So for me, this is a very good use of UBE. This is another one that I think that I argue that the tubular surgeons will really struggle with this, because I've got practice partners who use tubular surgery and they can do over-the-top decompression very well. But one thing they can't see and do very well is the contralateral exiting nerve root. They struggle with that. So I've got an 82-year-old man with hemophilia, proper hemophilia that needs factor VIII, had been struggling with severe right groin anterior thigh pain, 2 hospital admissions, and nerve root injections. So if you look at MRI there, you can see that he's got lateral recess stenosis causing L3 nerve root compression coming from a combination of disc and lateral recess facet hypertrophy, and also exiting foraminal stenosis causing L2 nerve compression. So you can see that on the CT and standing X-ray, you can see the L23 disc, 3-4 disc is collapsed on the right side, which is the side where the nerve is compressed. So in this situation, what do we do? Do we do a fusion? Do we do a decompression interlaminar, or we do it transforaminal? So for a uniportal person, if they come in transforaminal, then the SAP of L3 will be in a way, right? So if you look at this, this is a diagram I've taken from the seminars in spine surgery. You can see the SAP has got two elements, the lateral element, which is outside the spinal canal, and the medial ventral aspect, which is inside the spinal canal. And the lateral aspect is the one that gives you the pillar effect that holds up the collapsed disc on that side. But the nerve root compression is virtually always from the ventral medial aspect. So if we go paracentral, we have to resect the lateral aspect, which gives you the stability to get into the foramen and the canal properly to decompress the lateral recess. So if we were to do that, as in this case, the L45, L5S1, the SAP has been resected somewhat from the lateral aspect, and you can see the patient has gone into progressive collapse on the operative side at L45. So for this man, I didn't want to do a far lateral approach because I will have to resect the lateral aspect of the SAP, which would then lead on to progressive collapse of that particular motion segment. So what I did is I did interlaminar from left to right approach. So the compression is all on the right side. So I went from the left side over the top, and you can see here that's the foramen L23 SAP here preserved mainly, and I can decompress by pulling out the flavum in the foramen, and you can see the L2 nerve root there quite clearly, and at the same time I can take out a contralateral disc. So I've decompressed the foramen, contralateral foramen, I've decompressed the lateral recess, and also did a discectomy all through the same approach. So I couldn't do this safely through a transforaminal extraforaminal approach, and certainly a laminectomy would make it very hard because I'll have to resect most of the facet joint, leading to progressive collapse. So I think this has been a really useful tool for me with this sort of cases, which used to be extremely challenging. The radio frequency has been really helpful because in the foramen you get radicular vessels that could bleed substantially. And I had to work around finding different radio frequency ones that work for me. Some of them are very good with ablation, but really too aggressive for coagulation. And some, like this one here, is really good for intra canal work, but it's not as good in terms of ablation. The other thing that I found useful when I do degenerative type scoliosis is a lot of patients have L5 nerve root pain because of the end plate osteophyte causing compression, and it gets the exiting nerve root. So it's very useful because the scope lets you go extraforaminal, contralateral interfat laminar, and ipsilateral interlaminar, and different techniques using the scope gets you a different area of the foramen and extraforamen. So this is a case I did 2 nights ago, and I didn't get the right diagnosis. So this patient a year ago had L2 to L5 central decompression for bilateral neurogenic claudication. After surgery, both his leg pain were gone for a year. 8 weeks ago, started getting sudden onset right leg pain in an L5 distribution, very severe. And the L5 nerve root is very tight there. We can't work out whether it's a disc, osteophyte, or a problem coming from the L4-5 level. So on an MRI, it's not very clear. There's some tightness there, but you can't really see a lot. You can see a bit of a nerve root, and you can see on the CT there is a little end plate osteophyte hooking in. I got a second opinion, and he thought that might be the problem. So I went, rather than doing an A-lift, which will open up the foramen height, but that spike of bone there can still catch a nerve root and cause severe radiculopathy. We see that in A-lift and PLIF patients sometimes. So I went and did a extraforaminal UBE, and I made the wrong diagnosis, because when I went down there, I cannot see the space between the TP of L5 and the sacroiliac. There's no space. And because I couldn't find any space there, I just didn't know where I was. I kept doing x-rays telling me I was in the right place, but I wasn't. And finally, the penny dropped. This guy has an undiagnosed bilateral syndrome. So there is no space between the TP. There's a bit of space, but filled up with fibrous tissue and ligament. And I had to put an osteotome, essentially, into the sacroiliac to crack it. And then you can see there's a floating fragment of bone here. That's the osteotomized sacroiliac. And then I have to drill away the part of the TP or L5, which usually looks really abnormal because it's just a nubbin that doesn't look like L4, L3. And then the nerve root just essentially popped out dorsally. And that's when the penny dropped, that I completely missed the diagnosis of a bilateral syndrome. But it doesn't matter, because, you know, with the scope, you can move around fairly easily and you can see. If I committed to interlaminar approach with open surgery, then it's very hard to come out laterally. So with this one, I can move around and worked out what was going on. And once I've decompressed the nerve root, I went under the nerve root to find that end plate osteophyte. But the end plate osteophyte wasn't really causing any problem, because when I went down to look for the end plate osteophyte, a piece of 8 centimeter by 3 centimeter sequestrum of this popped out. So I missed 2 diagnoses in this situation. And I think the pain was very severe because he has got chronic viral syndrome, and then on top of that had an acute disc herniation, but because it's so tight, you couldn't see it on the MRI. And as you can see there, the II picture, we can decompress from outside all the way into the canal. And also, this is a really fat patient. On the Wilson frame, the gut has been squeezed into a tube, and you can see the black bit. You can see the black bit here, which represents his belly obscuring the X-ray view. So this UBE technique has been a lifesaver for me because I got the diagnosis wrong. And this is a technique that I find useful because with uniportal, you have got one hand doing the whole work. In this situation, this is a retired doctor, very, very tight canal stenosis, UBE over the top, and this is the far lateral, the contralateral side on the right side, cephalad, chordate, lateral medial, and the nerve root of L5. When they pull out the flavum from the contralateral side with the SAP, there was a dural tear there with a bit of root that's floating out. So I put the root that's back with the dissector, and I tried to seal it off with a Tecoseal. The problem with that is that Tecoseal keeps floating out of the way, keep floating out. So what I did was I get a system to hold the endoscope, and through the working portal, I put a little dissector, held the Tecoseal while I let my micropaturi go. And with that, I can make that thing stay well and smoothen it out and basically seal it off. So when you find you need a third hand, you can actually do it with UBE, which is not possible with uniportal. Thank you very much. I might be out of time.
Thank you, Stephen. That was brilliant. And you obviously experiencing some advanced pathologies and techniques using UBE, and it's great to see. Yeah, that Barrow syndrome is a known entity, and it can catch people. So that's really
Yeah.
good discussion.
Not great at 9 o'clock at night.
No, it was great. All right. We did have Elsa Gonzalez from Spain, but she is unable to join right now because she's in the middle of surgery. We have to understand that in Seville, it's 12 p.m. over there. So hopefully she can come online. But in her place, we have Dr. Kuan Yu from Singapore, who has some case examples that he will share with us. And we'll see if Elsa can come online. Dr. Kuan?
Okay. Hi, good evening, everyone. Thank you, Mr. Choi, for the invitation, and thank you, Mr. Yang, for the very interesting case. So I'm Kuan Yu. I'm a consultant from Singapore Woodlands Health. I'm doing a fellowship with Dr. Choi at the moment and learning advanced techniques on UBEs. So today we have two cases that we want to present, one on lumbar and one on cervical spine. So case one, so our patient is a 34-year-old lady with a previous history of a hip FAI with a previous scope done before. Now, 2 years back, she saw a doctor for low back pain with left lower limb radicular symptoms, no lower limb weakness or numbness, and she claims that this pain is totally different from her previous hip pathology. And she went to see her doctor and did a MRI scan 2 years back. The MRI scan shows that there's a bit of a disc bulge with a bit of a lateral recess stenosis on the left side. So she was managed conservatively with medications as well as physiotherapy. So she endured the pain. Subsequently, 1 year later, her pain gotten worse, and then she repeated her MRI scan and shows that there's the large disc protrusions causing central stenosis. So at that point of time, 1 year ago, she went to see pain specialist, and she had right-sided lower limb radicular symptoms as well. And the pain specialist managed her with a steroid injection, and she went for 3 of them. And over the 1 year period, her pain was fairly severe, and then she requires a high dose of gabapentin, 500 mgs twice a day, clonidine, lidocaine patch, and then she couldn't take it, and she repeated the scan again. And this time around in June 2025, which is just this month, the MRI scan shows that the prolapse disc gotten even more severe, and it's causes almost severe obturation of the central canal. So she came to see us at this point, and then we spoke to her and we counseled her for operations, and we did some investigations. And the X-rays over here shows that there's a transitional vertebral over on the sacral S1, and then there's a Bertolini's syndrome, collapse of the disc base over an L5S1, and there's a bit of a anterior tilt of the L5 vertebral. So at this point, then we'll be thinking, what should we do? The option would be, whether should we do a fusion or should we do a discectomy? So, can I invite Mr. Yang, Mr. Stephen Yang? Oh, yeah. In this patients, 34-year-old young patients with this radicular pain as well as prolapsed disc, and with reduced in the disc space in the L5S1, what would you consider? And would you do a UBE discectomy for her, or will you
Where's
go
the
for?
disc herniation again?
Oh, so it is central.
Central?
Yeah.
Yeah, and her symptoms, well, I think if she has a lot of pre-existing back pain, you could definitely make a case for doing a fusion because you can pull the disc out from the front. But, if her main issue is leg pain and the back pain is not really a big problem, And someone's young, if you can counsel them and say, look, I can improve your leg pain substantially with a discectomy. You may still have back pain, but I haven't burned any bridges, because you can always fuse later. In a young person, anesthetic is not an issue. But if you do a fusion, you can't undo a fusion. So there's a discussion I always have with patients. And quite often the younger patients just go, yes, just do a discectomy. Particularly, in fit, healthy and strong people, they can deal with a degenerative disc. In the obese patients and who has no core strength, that's a different story.
Yeah. So, I mean, absolutely. So, I mean, because she's young, I think her back pain when she saw us wasn't so severe. It's mainly her radicular pain as well as a weakness over on the S1. So we talked to her intensively, and then she decided for discectomy, because she understood that, I mean, subsequently she may still requires fusion, but I mean, that one maybe years down the road. So for her, we perform UBE discectomy. So in these patients, what we did a little bit differently is that, I mean, normally we'll use osteotome to remove to perform some bone work as well as to remove the flabum. But because it's so tight in the space, we did meticulous burring as well as using a Carrison punch to slowly remove the flabum and to ensure meticulous hemostasis and to give us a very good view. So over here, you can see cranial caudal midline as well as lateral. We are standing on the left side performing the UBE. And then you can see that there's the nerve are very, very compressed. And then now we are using the probe to create a space between the thicker sac as well as the annulus, the disc. So to slide across. You can see that there's very big disc bulge over there, and it's pushing the nerve up. Now, what we do, we remove the scope, put in the half cannula, and then push it in lateral to the nerve, sliding it across and pushing it to the midline. So this gives us exposure to the disc, and then to protect the nerves. Okay, go a little bit more. So always ensure hemostasis before performing any discectomy. So now we will slide in our probe and to do the aneuploidy. And you can see that as we put in the probe, I mean, this material starts to come out. And then at this point, when you are pushing in the cannula, you can put in some pressure, downward pressure through the cannula, and this can assist in pushing the disc material out. And what we do with the probe is to free up some of the adhesion, I mean, over on this material, and subsequently using pituitary ronger to slowly remove all the disc material. As we remove at the end, use the RF probe to ensure that we secure the hemostasis at the end. And now you can see that the nerve is adequately decompressed. Okay, so for learning point for this case that we had was that we avoid using the osteotome in a critically tight canal, especially when she had a little bit of a weakness over on her S1. So to avoid causing additional trauma to the nerve, and we use the sleeve to assist in retracting the dura and to exert gentle pressure on the sleeve to squeeze the disc material out. So now we'll move on to the second case. So we have this 83-year-old lady had previous L3 to 5 lift with posterior fusion a few years back. She developed neck pain and right upper limb radicular symptoms for 6 months duration, had issue with her hand dexterity. She had no unsteady gait, and examinations showed that she had right upper limb weakness over on the C6 and C7 with no Hoffman or any other signs of myelopathy. So this are her CT scans. You can see that over on the C5, C45, C56, and C67, there's bony osteophytes over on the foramina and causing foraminal stenosis. And on the MRI scan, you got your mid sagittal in the middle picture. There's no myeloma, there's no port signal changes, but on the left side, you can see that there's a right oblique view showing that there's foraminal stenosis. And these are her axial views. So, Mr. Yang, for these patients with multi-level foraminal stenosis, C45, C56, and C67, with mild weakness over on the hands, but no myelopathy, what would you do for this patient in an 83-year-old lady?
So, for me, I think people that do multiple level neck surgery, like 3 or level ACDF, are just being lazy. So usually just because they have got stenosis doesn't mean it's symptomatic. So it's your job to work out which nerve is giving her the symptoms. I think for most cases, you can narrow it down to 1 or 2 level. If it's in the hand, it's got to be C6 and C7 or C6 or C7, right? So I would do differential injection and work out which nerve is the main problem. So that habit formed because I was doing ACDF a long time ago, and I don't like to do a 3-level fusion. I really hate it. So I usually narrow it down to 2 levels, and this is what I'll do. So endoscopy doesn't change how you treat patients, right? You still have to do your diagnosis right in terms of history examination. Just because you can do something minimally invasive doesn't mean you can do more of it in a more blasé way. So you still have to go down a diagnostic path and work out where the issue is. And don't forget, a lot of old people, they've got hand symptoms and it's due to carpal tunnel syndrome or cubital tunnel syndrome, right? So every week I see referrals for necks because the scans show this degeneration, but in fact, on examination, they've got peripheral nerve problem. So this is the way I approach the patient. And then if you can narrow it down to, 2 level, then it's dealer's choice what you want to do, right? So, and if she's got a stable neck and you've got foraminal stenosis and you can narrow it down to 1 or 2 level, you can do the front, you can do the back, and suddenly, like I showed a case before I did doing a UBE or even uniportal, you can actually, because the neck is quite small, you can sweep up and down very easily, getting to 2 or 3 levels. The only issue for me is that when you get bleeding in the cervical spine, you have to have the right tools to control it. When I did my first case, I didn't really have the right tool to control it. And around nerves that are very compressed for a long time, once you release it, you can get a lot of bleeding and you can't see. And you're not dealing with dura, you're dealing with the spinal cord, right? So this is when, it does get a bit hairy. And I didn't have the right, micro RF to stop the bleeding. I had the big stuff. So you got to have the right tools around.
Yeah, absolutely. The bleeding in cervical spine, it can be torrential and it can be a rich screen, and it's quite hard to control at some times, and then you just got to abandon it. So, in this case, in a lot of places probably will be doing open foraminotomy, or in some places they will do a ACDF from anterior. So in this patient, we evaluated and we went on to do 3 levels foraminotomy through endoscopic. And this is how we set up. A pro injection table with a chest support and then with a foam for the head to allow the neck to be in a bit of flexion. We tape down both shoulders as well as the head to stabilize it and to remove the skin creases. And then this was the view from the endoscope. So over here, this is the C4 5 level. This C5-6, you can see that the nerve roots is adequately decompressed. And then this is the C6-7 foramen, and with the nerve over there. In this view, we can see all three levels through one portal, but during the operation, we actually needed to create additional portal to decompress the top level. So you can see that this in this endoscope, this was just before we finished, when the view was clear, there's no bleeding, everything is good. Patient woke up, everything is well. When the symptoms improved, her weakness got better. But 2-3 days down the road, she developed increasing weakness over on the right hand with issue with the dexterity, but the gait was okay. So we proceeded on to do a MRI scan to see how was the decompression, and we found that there's actually a hematoma over on the C5-6 as well as C6-7. In this patient, we did not put any drain. First, there was no bleeding when we were closing up, and then that the view was very clear. Now she is about 2 months post-operation, and then when we reviewed her symptoms got better. We did not go in again to decompress the hematoma. So in this case, my learning points were patient positioning and anatomical landmarks are quite critical in cervical UBE. This is because the space in the neck is actually very, very small. With with inadequate positioning and not adequate creating of the space within, you can get lost very easily. Second, meticulous hemostasis is very important because, like Mr. Young has said, bleeding in the cervical spine can be torrential because there's a lot of ligaments, there's a lot of feeding vessels to the nerve. And then what we use, in this case, we use the hook probe, to slowly hemostase all these ligaments as well as vessels before we really go down to the nerve. So when we see a little bit of the vessel, we lift it up with this hook probe, and then we hemostase. And then third, consider insertion of a drain. Whether your view is fantastic, no bleeding, but you will never know, especially in the elderly, because hematoma may still develop. Yeah. And so this ends the 2 cases that we prepared. And thank you very much. Thanks, Mr. Young, for participating in the discussion.
Thank you. Good cases.
Thank you, Kwan, for a great case discussion with assistance from Dr. Stephen Yang's comments. I think with this delay from Dr. Elsa's surgery in Spain, I don't think we will have opportunity to invite her for the lecture that she had prepared. Dr. Jacob O sent us a question to all of you saying that there's incredible amount of industry support for uniportal learning and courses available, but very little in the way of biportal courses. So all of you that have now either switched from uniportal or gone on to biportal, what would be your ideal learning method if you were to start again? Short answers, all of you, starting with Liam.
So, honestly, I would go and observe someone as the first thing, just kind of see how someone does it properly, because I think a CAD lab's a little bit too, simulated, I think.
Ophelia?
So I just think if we do tubular surgery and we are orthopedic surgeons, so it's easier for us to transit from tubular to UBE. And I think that it's getting more and more popular locally and in the Asia. So there are more and more support now available.
Dr. Kwon?
I resonate with Liam that you need to watch someone to do it, especially so for endoscopy, because you can see online, YouTube, how people do things in the scope, but what you don't observe is what the experts do outside of the scope. How they hold their scope portals, how they hold their RF probes, and how they maneuver. All these things is similar to how orthopedic surgeons do shoulder scopes. The scope view can be perfect, but you need to see how the experts struggle outside of the scopes. Yeah, so I'll say that going to watch live surgery with Dr. Choi and a lot of experts will be very important.
And Dr. Yang?
Well, the problem is twofold. One is that I think I do, because I have no one locally to help me. John has been a great help introducing me, but he can only come a couple of times to see me, do a couple of half cases. I learn a lot from watching YouTube and videos, even though I don't understand what they're saying. It's just videos. The second issue, I think, like I said before, you have to be very careful going to see experts. You can see stuff from them, but when you come back thinking you can do the same, you'll be very wrong. I tell people, if you're committed, you'll be prepared to suffer. Just, you got to suffer. And there's no shortcut around that, and I think you watch, but in your head, you think to get there, that guy's done 1,000, right? You don't know how he struggled previously as well. So that's all I can say. When I told John, look, I'm freaking struggling here. It takes me freaking 4 hours to do this case. He goes, you didn't see those guys fuck up in Korea. So it's the same thing that I think everyone goes through that. Some take us longer. My learning curve is longer, but I think if you're committed, you will get there. But there is some suffering involved in it.
Yeah, I think it's universal that a new surgery is going to have its obstacles and barriers in learning and mastering the technique, and everyone has learning curve to tackle. There are plenty of courses and lectures and webinars and workshops like this, and plenty of resources online. And there are many societies that are promoting this technique, so you can reach out to the masters. One of the avenues, yeah.
I remember when I finished my training, we went and did fellowship, and a couple of my friends in my cohort went and did shoulder fellowships. When they come back, they're trying to do, scope shoulder for everything repair, and they end up looking like a football. They have the same issue. Water everywhere on the floor. 3 hours later, they have the same issue. It's universal.
Yeah, it's universal. With that, on that note, we might ask Dr. Arvind Kulkarni, the president of SMISS AP, to just play this promotional video where you can learn these techniques through the masters at the Congress coming up in India. And I thank you, everyone, including, most importantly, our speakers that have given up their time tonight to be available to educate us. Thank you.
Thank you, everyone.
Thank you, John.
Dear friends and colleagues, I'm Dr. Arvind G. Kulkarni. I'm the president of this year's SMISS AP conference, which is a combined conference of SMISS AP, that is the Asia Pacific chapter of Society of Minimally Invasive Spine Surgeons, plus MISAB, that is Minimally Invasive Spine Society of Bharat, plus BSS, that is Bombay Spine Society. We have come together up on a platform to support and conduct this particular mega conference, which is going to be a mother of all conferences. Myself, Dr. Ayush Sharma, the organizing organizing secretary and the organizing committee have put up an academic feast. We'll entertain you with education that will consist of tubular techniques, endoscopic techniques, Destandu techniques, and you will have all the latest technology that is sweeping the MIS world. And this will all be happening at the famous Taj Hotel in this vibrant city of Mumbai. 3 incredible days. Apart from education, there'll be a lot of entertainment in terms of comedy shows, music, dance, etc. I'm sure you'll be coming from very diverse backgrounds, from very different countries, from all across the world, and we'll make sure that you go back with great memories that are full of education, knowledge, memories that will remind you of the cultural heritage of this great country and this great city of Mumbai. It's with great pleasure I take this opportunity to welcome you all, and I look forward to see you as early as possible. Thank you.
Thank you all. I look forward to seeing you in Mumbai, and we'll close this